What's up guys, welcome back to another video. It's currently 10 to 8 right now, just heading to the hospital. I'm only a few minutes away. I'm in ENT or ear, nose and throat this week, so I thought I'd bring you guys along for the ride today and kind of show you some of the things I do on a day-to-day basis. So let's get to it. All right, so it's kind of bumpy, but if I don't have time to get my coffee in the house, sometimes I bring it with me on the ride to the hospital, which is only like a 2-minute drive, so gotta kind of crank it in. All right, so we're gonna start the day now. I'm just gonna meet up with my team and do bedside rounds, so catch up with you guys in a bit. All right, so I'm heading to the theater now. Don't have too much time to talk right now, but I'll catch up with you guys after and fill you in on my morning. All right, so first operation of the day, I was just in theater. It was just a grommet procedure. Talk more about that in a second. I have a lecture to get to, so it's my one lecture for the day, so I'll have more time to talk about it afterwards. So yeah, it's an online lecture, so I'm just gonna go out to my tutorial room, watch it on my laptop there with my classmates, so touch base with you there. So I have a few minutes before my lecture starts, so I just want to talk about the procedure I was just in on. And sorry, it can get kind of hectic up there, so I didn't really have too much time to talk about it at the time. But it was a grommet procedure, and this is done typically for kids who have something called otitis media with effusion, otherwise known as glue ear. Basically a buildup of fluid in the middle ear, and it could lead to a type of hearing loss called conductive hearing loss. And if there's an audiogram done at one point that shows conductive hearing loss, it's typically done 3 months later. And if it's persistent and also shows conductive hearing loss 3 months later, then that's kind of an indication to get this grommet procedure done. So basically the surgeon makes a small incision in the eardrum and inserts this tiny tube in, and that kind of equalizes the pressure between the outside environment and the inner ear to allow air to get in, so it can kind of gradually through time kind of suck up the fluid in the middle ear. And children kind of have a flatter eustachian tube, which is the normal ventilatory tube in the human body that kind of equalizes the pressure between the middle ear and the outside environment. But in kids, it's more horizontal and also smaller, so it kind of basically just doesn't work as well, so they're more prone to these type of effusions in the middle ear. So I thought I'd also catch up on our bedside rounds in the morning. When I say bedside rounds, it's basically our ENT team kind of getting together and going to the patient beds and kind of speaking with them, checking on how they're doing and any progression in treatment, et cetera, et cetera. So more or less just checking in on the patient. So we had only 3 patients today, wasn't too busy. 2 of them were tonsillitis, one of them in a younger individual, I believe 4 years old, another in an adult. The last patient is one patient that we've been dealing with for a long time now. He unfortunately has a neck cancer called the squamous cell carcinoma, and unfortunately it's unresectable, so it can't be taken out. So we're kind of just treating his symptoms, but we're checking in with him. He's in good spirits, and it was good to see that he kind of had a smile on today. So my lecture today was on major trauma and shock. Really good lecture, learned a lot. And in major trauma and shock, we kind of go by the ABCDE formula. So A is airway. So this is in order of what you assess first and kind of attend to first. So A is airway, and that involves protecting the airway and making sure the airway is patent and maintained. If there was any sort of trauma towards the neck or a risk of, the neck being compromised as well, you want to stabilize the C-spine initially as well. B is breathing. So attending to their breathing, checking for chest rise and fall, and checking for the work of breathing and doing your inspection, palpation, percussion, and auscultation. C is circulation. So that involves checking for bleeding, checking for the color of the patient, checking for the temperature. D is disability. So that's what you attend to next. This is assessing level of consciousness, checking the patient's pupils, and checking for blood glucose levels as well. And E is exposure. That involves keeping the patient warm, exposing the chest, and inspecting the posterior surfaces or the back surfaces of the patient as well. So a lot of that I was pretty familiar with, but it was kind of honing in on some of the smaller details, which was good. So I'm gonna head back up to theater now, catch up with you guys in a bit. All right, so it's currently 1:15 right now. Just wrapped up theater for the day. Got to scrub in on some great procedures. The first one was a micro-laryngoscopy and excision of a polyp, so a benign outgrowth on the right vocal cord. So that was really cool too. The second patient had a basal cell carcinoma on the left nose that we excised and is going to be repaired in about an hour. So I don't think I'm going to be on that one because I'm going to be doing some stuff in the emergency department, but that's going to be repaired in about an hour. And the last one was a simple punch biopsy. The patient had a lesion on the left forehead and left cheek, and we basically took a biopsy of it, and you're going to send it to the pathology unit to test for cancer cells. So nothing was taken out, just a biopsy. So that wrapped up the morning of operations. So gonna go grab some lunch now, and I'll touch base with you guys afterwards. All right, so it's after lunch now. I just got out of theater and we touched base with the patient we had before. I said basal cell carcinoma. This is what we thought it was, but it actually turned out the cells came back negative for cancer cells, so everything was fine. We did something called a nasolabial rotational flap repair. So basically we took out the lesion on the left side of the nose, and we basically turned the skin over and sealed it up, sutured it. So patient looks good as new. That was a cool procedure to see. And then we also just talked to a few of the patients after operations, checked in how they're doing. That's actually it for the day. It's 3 p.m. right now. Finished earlier than I'd normally finish, but definitely not complaining. It's Friday. It's the first time I've actually mentioned that it's Friday. I decided to do this later in the week. I don't know, I kind of just got around to it now. I did film a couple things earlier in the week, so you pop those up if you're interested in what I did then. All right, guys, so on my ENT rotation right now, everything's been super interesting this week. Just wanted to say that I've got some really good teaching this week as well, and the people that I'm working with really pay attention to me as a medical student. I think that's something that I really do appreciate. I think a lot of things can get lost in the hospital and people are doing their own thing, and I do really appreciate when people put the extra time to actually pay attention to me and teach me some things. So had a really good day. Went for usual bedside rounds in the morning with the ENT team, so that was good. And then we had a patient who, really young guy, 21 years old, who was working out last night with a medicine ball and was doing the med ball slams, and he slammed it on the ground thinking that it wasn't one of the ones that bounced. It had his head leaning forward, and unfortunately it was the one that bounced. So the medicine ball bounced right back up, hit him in the nose. He fractured his nose in a couple different places, so broke some of the nasal bones and also deviated his septum. So we had to manually adjust his septum under local anesthetic as well. So we had one elderly woman with a basal cell carcinoma on the right part of her nose, so that needed to be excised. And cool to see as well when a patient has a lesion on their face, whatever it may be, and if something needs to get removed, that we can use another part of the body and place that skin graft in that area too to maintain a good cosmetic appearance. So really happy for her. In another procedure, we did a endoscopic resection of an antroconal polyp. Basically what that means is we took a camera, stuck it down the nose, and removed a non-cancerous outgrowth of tissue from the inside of the nose. To get a polyp removed of that size must be a pretty amazing feeling. So I was really thinking of the patient in that regard, and how their quality of life is going to improve as a result of this procedure. And the last procedure I saw today was something called an obliteration of the mastoid air cells. So your mastoid bone is this bony outgrowth behind your ear, and you have these air cells in there. Basically what it sounds like, pocketfuls of air. And it can be prone to infection in certain individuals for a number of reasons, but basically for this patient, he had recurrent infections of the mastoid bone, so it's called mastoiditis, and this was a procedure to kind of obliterate the cells in order to prevent future infections. So that was also cool to see, and really good day in ENT, but I'm exhausted. I'm gonna go home, take a nap, I think. So I'm gonna sign off for today, but we'll chat with you guys very soon. All right, guys, so just wrapped up. Good few hours of study and about to head home. But I thought before I head home, talk a bit more about some of the things I did in other days of the week. I know I gave you guys a perspective of what I did today, and it's pretty typical of a day in my ENT rotation, but I thought I'd talk about a couple things that maybe I did on another day that I didn't do today. So I watched some laryngoscopy, so putting a camera down the nose and examining the vocal cords of the patient. So yeah, in other days, it was a lot of history taking, clinical examinations, and also consenting patients prior to surgery. A lot of kind of bread and butter conditions you'd see in ENT, such as epistaxis or nosebleed, swimmer's ear, which is otitis externa, so that's an infection on the outside of the ear, otitis media, which is an infection at the eardrum, and otitis media with diffusion, which I mentioned earlier from the Grommet procedures. So lots and lots of conditions, definitely learned a lot. And lastly, I just want to say that everyone was so friendly this week. I only have a week in ENT, but really gonna miss it actually. And I definitely have a higher regard of ENT after this week than I had before, and honestly a higher interest level for it. So not really sure what that means, but we'll leave it at that. So I'm gonna head home now, and we'll see you out in the parking lot for the final regards. All right guys, that's it for the video. Hope you guys got a glimpse of my week in ENT.